Hi, Doug Mealy here from Safer Handling. Today I've been at Derriford Hospital in Plymouth delivering a soft restraint trainer update to our dedicated team supporting staff on the ICU. I got the chance after the course to catch up with the delegates to find out their thoughts on the kit and its implementation and the results they've had so far.
I'm the physical interventions trainer at Derriford Hospital in Plymouth, and so I cover a range of teachings of that. My job is all about delivery of training, or is mostly, and the core principle of that is delivering training around restraints and safe restraints. And sadly, we sometimes have to restrain patients, not just patients, but mainly patients. And mainly with that, and my teaching is very much around the idea that it's very much about protecting them from themselves. We very often see people pulling out things like central lines, NG tubes, tracheas, things like that. So it's not what people imagine. I think the word restraint conjures up this idea of force and violence and aggression, and I very much sell what we do isn't about that. It's all about trust and empathy and understanding. So it's a very different approach than perhaps other settings might have around restraints.
My name's Peter and my title is Lead Nurse in the Intensive Care Unit here at Derriford Hospital, University Hospitals Plymouth, and got involved with the Safe Holder system about 5 years ago when we were investigating how we could keep our staff and our patients safe.
Doug, I'm Emily. I'm a clinical educator here at University Hospitals Plymouth, working in the intensive care.
I started by asking Dr. Peter Bramfield how he'd found the experience of prescribing the kit in ICU.
Yeah, very positive. As you know, we identified we had a problem, I think it was back in 2016, 2017, with increasing number of violent attacks on our staff. We've recognised that we really do have a duty under health and safety to look after our staff, and so investigated what we could do to deal with these particular patients, and they tended to be waking up, emergency delirium, post-head injury, and they tended to be young, alcohol, drug abuse and mental health issues, and often strong. And we looked at various things on the market. Most of it was all pretty much sort of Ann Summers, if I can say that, and it was all a bit pathetic, and we would try it out and you could rip yourself out of it, and then I think Sophie found you, and I do remember going in that first day, seeing the kit, and to be honest I was horrified. I was like, no, come on, we can't, this is just ridiculous, this is too far. We had the day with you and begun to understand that actually this was the perfect solution for what we needed. So once we established a framework for its use, we've been using it now for, I guess, 4 years.
That sounds about right.
It is very consultant-led and it has been incredibly successful. For the people we've used it on, I think we've certainly got a number of case studies where we can demonstrate we've been able to wake people up rapidly and get them out of intensive care, out of the hospital, whereas perhaps traditionally we would have had to leave them a lot longer intubated, or we would have put our staff at risk of being assaulted and being harmed by the patient, or the patient themselves harming themselves, self-extubating, pulling lines and stuff out. And it has been very, very successful.
The patients that I've put it on and have woken up with it, they tend to wake up a bit calmer, perhaps, because they realise they can't move too much, and they tend to respond quite well to it.
I mean, we can chemically sedate them, can't we?
Yeah.
It's just that as they're waking up, or even they can be awake.
I think there are spiders coming up the ceiling, the building's on fire, they're fighting and fighting. It's not necessarily they're purposely malicious and aggressive.
Of course not, no.
I know, not within the ICU, but a different department, someone was telling me with a different type of delirium, the patient had a genuine belief that he thought he was in hospital because we were going to harvest his organs. Right. So you can see why he would be combative. And that people wake up and they're all over the place.
Very often the consultation process to implement soft restraints across any sector is one with patient involvement. I wanted to see if Emily had any feedback for me from the parents or loved ones of those in their care.
The families don't seem to mind it. They seem to they understand quite quickly that it's to prevent harm to the patient, to themselves.
Yes.
And that it's all doing good.
I sort of imagined that was going to be our biggest problem. People go, what are you doing? But actually it hasn't. And as you said, people have recognised why we're doing it, and they recognise that it's appropriate and proportionate to the risks, and they've been very positive.
As someone who's not originally from a clinical background, I always want to get the views of people that work in the ICU, but also who are involved with the training side of things. Here's Richard's view on what he thought of the kit as a PMVA tutor.
When you talked about how you saw it the first time, I thought, oh my God, what's this? And the first time I saw it, I thought, this is great, because it's less hands on people, so it's that kind of perspective. Straight away, I wasn't alarmed, so this is a really positive thing, because there's less force going into someone.
Yes.
And that's nothing but a good thing. So, and as we've discussed, I've always sold that idea, so you can come in and you can sell it as saying, well, this is here to stop them from hurting themselves. It's not we're pinning them down, we're just stopping them from pulling out essential items. So that's kind of been your experience and feedback with it, isn't it, from what I've heard from everybody.
Yeah.
But yeah, no, straight away I looked at it and thought, this is a really interesting thing from my perspective, really. We talk about physical restraint with people. Obviously that's traumatic, potentially physically, but also can be very traumatic for that person emotionally. But people forget about us as well.
Yeah.
If you're having to restrain someone that you're here to care for, because people get into healthcare because we like people.
Mm-hmm.
Having to restrain someone for a prolonged period of time is really distressing.
Yeah,
And
absolutely.
if we
It
can
goes
reduce
against
that
it.
time by using a mechanical system instead, then
Yeah.
that's better for all of us as well as them.
Placing handles on the body, the soft restraint kit has enabled staff to maintain control of